And so with that, we do know that cystic fibrosis affects the whole body. And this is not an exhaustive list of some of the organs that are affected, but it gives us a feel for really thinking about head to toe what can be involved by CF. And we can see on the right-hand side a chart that shows us that over 90% of people with CF are going to have at least one complication. And those are a couple of the most common complications. And the pattern that we see is that complications increase with age. And so this is our session outline today. This is kind of a way that I conceptualize wellness and health in CF with the different domains here. And we have lung health, we have GI health, we have nutritional and endocrinology health, we have pregnancy, reproductive health, and we have mental health. And of course, at the top, we have lung health. And in the middle, what we're not going to cover today, which is going to be, the topic of other sessions, is infections. We know, so this is non-infections. And in the green, we have an entire session right now, another breakout session that's dedicated to mental health. So we won't cover that here, but we welcome you to attend that as your second breakout session later this afternoon. And the topics we will be touching on are on the right here, advanced lung disease and transplant. Two GI topics, both liver disease and colorectal cancer, CF-related diabetes, and then lastly, reproductive health. So I'm going to let Erin come up and tell us, walk us through advanced CF lung disease and what that looks like. Erin.
Thank you, Whitney. Hi, everyone. Hi, everyone online and in the room. It's a great pleasure and privilege to be here on behalf of the Cystic Fibrosis Foundation and kicking us off with a topic that is obviously near and dear to my heart, advanced CF lung disease and lung transplant. And so we know while the quality of life and survival of individuals with CF has improved drastically, we've heard that throughout this conference, people are still living with and facing advanced CF lung disease. And this can be associated with increased exacerbations, worsening clinical symptoms, and a reduced quality of life. And advanced CF lung disease is currently defined by the criteria you see here on the slide. An FEV1 of less than 40% is the most commonly used marker, but there are many other indications as we see here. I'm not going to go through all of them, but some of them are ICU stays because of pulmonary exacerbations and respiratory failure. Referral for lung transplant is another indication of advanced CF lung disease. And we know there are also individuals with an FEV1 of greater than 40% who don't meet any of these criteria, but may have other criteria indicating advanced CF lung disease, and they warrant closer attention. In 2019, we launched a dedicated section of the CF patient registry to collect data on people with advanced CF lung disease. We wanted to make sure that we had the data available to help us better differentiate and define advanced CF lung disease, help us figure out why some people remain stable for many, many years versus those that decline rapidly and needed an urgent transplant. So this graph shows the age distribution and the use of Trikafta in people in this part of our registry from 2019 through 2021. The majority of people with advanced CF lung disease, as you see here, are between 20 and 40 years old, and about 90% were on Trikafta at the end of 2021. Fantastic news. But we do not know the long-term effects of Trikafta for this population and how it really impacts those with structural lung damage. So one of our main priorities in 2023 is to start looking at and interrogating this data, getting it ready for researchers to use to investigate and help us answer these critically important questions for our advanced lung disease population. We've done a few things to help support our community, our care teams, people with CF, their families who are facing advanced CF lung disease and possible transplant. We've developed advanced CF lung disease guidelines. And clinical experience suggests that there is wide variability in practices on how we manage someone with advanced CF lung disease. So we put these recommendations together with a multidisciplinary care team, care members, to help us better customize the care that people receive. And we know there still needs to be specialized care for this group. Multiple issues are addressed in these guidelines, such as medical management, managing comorbidities like CF-related diabetes, GI and sinus complications, and advanced care planning. They were published in the Journal of CF in February of 2020. Next, We have heard loud and clear since we started this initiative 5 years ago, and even before that, from people with CF, their families, CF care teams, transplant care teams, that there was a lot of frustration about the referral process to a lung transplant program. It was perceived by many to be broken and a lot of variation in approaches to practice. We've also learned that hearing about lung transplant when your health is rapidly declining is extremely difficult, and it leaves very little time to prepare. So this drove the CF Foundation to develop transplant referral guidelines about when the best time to start talking about transplant, when to consider referring someone for transplant, for an evaluation, further education, and discussion with a transplant team. These were published in the Journal of Cystic Fibrosis in 2019. Now we're going to transition to transplant. And I also think we saw this earlier from Bruce. I don't have the fancy updated 2022 data on this one, so we don't have to go through it in detail, but really I think the message here is the introduction of modulators such as Trikafta has clearly resulted in an increased median predicted survival and sharp decreases in the number of CF lung transplants being performed. So this graph shows just that, volumes by year of data from the CF patient registry, and you can see that the number of transplants in 2020 and 2021 dropped drastically. In 2021, we had a total of 54 individuals with CF who were reported as receiving a lung transplant, compared to about 250 or more in the few years prior. This chart shows that we have about 2,000 individuals who are alive in the registry today who are reported to have ever received a transplant. Now, this is all organs, lungs, liver, kidney, very few hearts, but they're in there. 1,700 of those, approximately, are alive, have had a lung transplant. That's a big portion of our community, and we owe it to that part of our community to support them and make sure that they have the best quality of life possible. Many people with advanced CF lung disease have improved to the point where we've been able to remove them, or they have been removed from the transplant list because they're too well for transplant at that time. It's pretty amazing, but still we know not everyone in our community has access to modulators. Some don't tolerate them. And in addition, as I mentioned earlier, especially for those with structural lung damage, we're not quite sure how long they are going to remain well before needing a transplant. So we continue to be fully committed to our advanced CF lung disease and post-transplant population. These are a few of our transplant highlights, broken down into research and clinical, and this is definitely not comprehensive. We could spend all day talking about what we've done in the last 5 years, but I think it's really important to mention when we started this initiative 5 years ago, it was a very modest investment at that point. Fast forward 5 years, we've invested over $50 million for transplant and advanced CF lung disease research and clinical care, which is remarkable. Yeah. So I'll briefly go through some of the highlights. Some of the research highlights are our CF lung transplant biorepository and registry, which Bruce touched on briefly this morning. This is a registry we have put together with the help of our 15 lung transplant programs in our consortium. We're collecting biospecimens such as blood and fluid from the lung when they're having bronchoscopies. We're collecting data that we are looking for some indicators of what we call chronic lung allograft dysfunction. That is really the big elephant in the room when we talk about long-term survival after transplant. For people with CF who have undergone lung transplant, the median survival after transplant is 10 years, which is great compared to other lung diseases, but that is not good enough, right? Our patient population are being transplanted fairly young. And so when we hear that 10-year number, we're not okay with that. So we've put together this consortium, have invested a lot of resources into looking into chronic rejection. Within 5 years after transplant, half of the transplant population will develop chronic rejection. So we have been laser focused on this area with our biorepository, funding a study called the clinical trials in organ transplant. There are 5 programs that have been collecting data the last couple of years. There are about 1,000 people enrolled, and 100 of them are people with CF. And so there's this huge bank of data and specimens that we have continued to fund to allow investigators to study chronic rejection. What leads to it? How can we prevent it? Hopefully one day we can treat it. Ultimately, preventing chronic rejection. We've also put together a group of experts to focus on gastroesophageal reflux in lung transplant. There was a workshop series this past year, and hopefully some great work will come out of that. As far as clinical care, we've developed post-transplant guidelines. There are certain things for people post-transplant that need to be managed differently because they have CF. And I just want to make sure we remind everyone that even after you've had a transplant, you still have CF everywhere else. If you have CF-related diabetes, that does not go away with a lung transplant, nor does liver disease or sinus disease or any of the other complications that people with CF face. So we put together the post-transplant care guidelines back in 2021 to help transplant providers provide the best possible care for people with CF after transplant. Most recently, we're very proud of a new publication. It's a position paper in the Journal of CF. It was just published a few weeks ago, focusing on models of care post-transplant. What is the best model of care, right? We need to make sure that people still receive high-quality CF care after transplant. So this paper delineates different models that care teams can follow to help take care of patients after transplant. And then lastly, I'll end this section with a new allocation system for how we allocate lungs. Prior to March 9th, we allocated lungs depending on proximity to the donor. So 250 miles was the circle that was drawn to say whoever is sickest within 250 miles will get the first offer. We've done away with that, which is tremendous. It's been a couple of years in the works, and Dr. Brown has been very instrumental in her other roles in helping get this moved forward. But now we have what we call a continuous allocation system. So the lung allocation score and system that we used to use no longer exists. It's now the CAS. And this is really, I think, going to be impactful for people with CF because it includes things that were not included before. One of the big things it includes is survival after transplant, looking at 5 years. We used to use 1 year survival, for people with CF was not the greatest indicator. The 5-year survival after transplant is a much more accurate representation of our population. So we were really excited to see that included in this new system. And it also gets rid of those geographical boundaries, right? You do not have to live within 250 miles to get that offer if you are the sickest patient. So it really makes it a more equitable system. And we have been very involved in our advocacy efforts. We do that very well at the foundation. So our colleagues have really helped us get in front of the United Network for Organ Sharing and state our case and put in public comments to help support this change. So we're really proud of that and excited. And then I'm going to have Dr. Brown explain the picture of the cake before we move on to our next section.
Sure. I just want to point out we've been hearing the importance of stories, telling our stories and sharing that with others. And so this is a story that kind of keeps all of this tremendous work that the foundation's doing is very real, is that this is a lung cake. I don't know if you guys can see it. It's kind of taken from the side. This is one of my CF patients at Inova. He invited me to his lung anniversary party, which was his 1-year lung anniversary party. And that you can see that he had some crazy bakery do 2 cakes that were like drawn together in the middle by a trachea, and and nice and pink and healthy lungs to show us what his lungs look like on the inside. So ultimately, everything we do with all of these programs, we have to remember that we're doing it for the individuals who each have their own very important story. So just wanted to share that. Let's see. Now we're going to change gears a little bit. We're going to kind of do this in chunks. And the next chunk is we're going to talk about colorectal cancer. And Dr. Marshall touched on this. And March is Colorectal Awareness Month, Colorectal Screening Awareness Month in general. So it's appropriate time to talk about it. But this is a video that the foundation made before the pandemic that I actually hadn't had a chance to see until recently, so I resurrected it, and I think it is a good place for us to start, and it's entertaining as well. Oh, other direction, right? Here we go.
People don't know what that is, so I've All
process.
food groups are represented. What do they here right now?
Hey, everybody. Thanks for coming out on such short notice. Lungs and colon are on their way. You all know the plan, right?
Yep, we gotta convince Colin to get a colonoscopy. I don't think he understands how important it really is, especially with our cystic fibrosis.
Pancreas, I am a bundle of nerves.
Don't overthink it, brain. Keep cool.
Shh, they're here. Hey.
Yo.
Hey, Colin. How's it going?
Fine. What are you guys all doing here?
We,
Need to talk.
What's going on?
For starters, we all love you and we're worried about you.
really worried.
With our cystic fibrosis,
We need to...
take care of ourselves.
Oh, yeah.
You're putting yourself at risk.
And us, too.
Yeah, did you know that colorectal cancer is the third leading cause of cancer death? And that because of our CF, you have 5 to 10 times greater risk of getting it?
Oh,
Wow, no.
and I've heard that if you have a CF-related transplant, the risk is 20 times greater.
It breaks me to think about it.
Have you...
Been screened yet?
I haven't had the time. I've been dealing with a lot of crap.
It's okay.
We are all under a lot of pressure. Yeah, right. We're just trying to help.
Well, Brain, maybe you...
Can explain it.
Certainly. So, there are these little polyps that can grow inside you. And since we have CF, they can start growing even earlier in life. The longer they're left alone, the greater the risk of them becoming cancerous and spreading to the rest of us.
Who knows what'll happen?
If it turns into cancer.
Whoa. It's okay. Breathe.
Stomach's right. With a colonoscopy, your doctor can find and remove colon polyps before they turn into cancer.
And that's why it's so important for people with CF to get a colonoscopy every 5 years, beginning at age 40. And at 30, if you've had a transplant.
Geez. I don't want to put you guys in danger.
It's all right. We're here for you.
And so is the CF Foundation. They even have clinical care guidelines that help you and your care team choose the best approach for your colorectal cancer screening.
Okay, so what should I do?
Well, for starters, talk with...
Our CF care team.
I've got a good feeling about this.
Oh, you guys are the best.
Yes.
How about this?
You go with that.
Right then.
Very cute. All right, so we'll have a quiz on the ages later. We'll repeat the messages that we heard, but let's start with a little bit of data. This again is this is not in the official annual data report that Dr. Marshall gets so excited about. This is actually data that we specially requested from our registry team, and this looks at how many people over the last 4 years. It starts in 2019 and then moves forward. How many people in the registry reported that they had a colonoscopy, and these would be adults, eligible adults, and you can see that from 2019, 2020, 2021, 2022. We see an increasing pattern there. Of course, 2020 was a little bit of a wash that everybody put most of the non-essential medical care on holding, and so the numbers went down that year. But we can see that there's a general trend that people are getting more screening. But you say, and in particular in 2022, it looks like about 830 people reported getting a colonoscopy with CF in the registry. But we have to take a step back. How many people were eligible or in the age range where they should have gotten screening? And that's if you take people that are over 40 with CF or over 30 with a transplant, that sum is about 5,500 or 6,000 people. Now, you don't need a colonoscopy every year, so if we divide that by 5, getting a colonoscopy every 5 years, we still got some work to do because it looks like maybe a little over half of the people that should be screened each year are getting screening. And this table really shows us, so what are the findings on colonoscopy? And you can see over the years, it's the same graph we just looked at, but now the blue color represents normal colonoscopy findings. So that's obviously what we want to see when people have a colonoscopy, that it's normal. The purple is a really frustrating situation where it's indeterminate. And you say, well, what does that mean? That means that they couldn't see well enough or they couldn't complete the test. And in CF, we know because of sticky body secretions and intestinal secretions that it can be a a little bit more difficult to get a really good clean out before a colonoscopy. And so, in fact, a lot of care teams will share special protocols or special prep instructions for people with CF so we can avoid that really annoying purple scenario, because there's nothing worse than spending your time getting ready for a colonoscopy. Some of you may have experienced that yourselves. I did recently, and then having them tell you, no, you have to come back because you weren't ready. So just a special nuance there for CF. And then in yellow is the polyps. So you heard on the video, the polyps are these abnormal growths over time inside of the colon that over time can become cancers. And that's really what we can intervene upon, right? In the colonoscopy procedure, they can remove those, prevent the future development of cancer, and that's really a win. So the yellow are, it is like, wow, we really made a difference. The red bar at the top are the number of colorectal cancer cases that were actually diagnosed on the screening colonoscopy. And we can see, although the numbers are small and we hope they were very early stage, we want more yellows and no red in the ideal world if we're screening at the appropriate time. So the challenge is to raise awareness. And you'd be surprised that there's actually some GI physicians that don't fully appreciate, they don't see CF patients, they may not even know about the increased risk of colorectal cancer in people with CF. And likewise, we really need to make sure our care teams and our patients and families understand that risk and can advocate for themselves and know when they need to get the appropriate screening. And again, at the bottom there, I put the cute little jug. You guys may have a PTSD from doing it yourself, of Go Lightly there. That is what we ask people to drink is a clean out. And just a reminder again, screening for people with CF beginning at age 40. The general population, as of a few years ago, changed to 45. Used to be 50. And just within the last couple of years, general population's 45. So that's a 5-year difference there. And then at transplant, after any transplant, starting at age 30. And then, of course, if there's any symptoms concerning GI symptoms before those age ranges, then a colonoscopy could be appropriate even sooner. But colonoscopy is a big deal, and right now that is the standard of care in cystic fibrosis, but this is a study that the CF Foundation is funding to look at, could there be a role for some other screening tests, either in between the 5-year intervals of the colonoscopy, or to tell us how urgent a screening colonoscopy might be. And you guys have heard of the stool-based test, where you get you mail in a sample and then you get a sort of a risk score of, do you really need the colonoscopy or is it looking pretty good? Right now, this has no role in CF because CF is considered a higher risk population. But the question is, could it be used in between colonoscopies to really hone down on the right timing? So this is a study of people that with CF that are due for their screening colonoscopy. You can go online and there's a CF clinical trial finder, and you can, or you can Google Nice CF and you can sign up for the study. They mail you enroll remotely. They mail you a kit to do the stool-based testing. You mail it in, and then they review and you share your colonoscopy results, and they are accumulating evidence of many people who have both tests at the same time to see how well they correlate. And again, this could make room for the stool-based testing in the future, but I do want to say, the stool-based testing doesn't remove polyps, as we just talked about. So right now, really, colonoscopy is the gold standard, but looking at how can we nuance this or make life potentially a little bit easier in the future, would that be safe? Next, we'll move a little bit higher up in the abdomen, and we'll talk about the liver. And you can see the liver is the organ right there at the top. I don't have a pointer, but the big organ at the top in red. And running through the liver in blue are the bile ducts. And this really, if you want to simplistically think about why does CF affect the liver, we talked about sticky body secretions or mucus in any sort of tube, whether it's the lung, whether it's the intestine, whether it's the bile ducts, all over the body can get sticky and blocked up. And when bile ducts get blocked up, even at a very young age, it causes inflammation and it can cause tissue damage in the surrounding areas. And in some cases, that can lead to even scarring of the liver. So that's a very simplistic way of looking at it. But in general, we think of CF liver disease as kind of a wide spectrum. So I put the two main concepts, or two definitions we should know about it up top. So we have advanced CF liver disease, which sounds really similar to advanced CF lung disease, so the acronyms are a little tricky there, but that essentially means that there is structural damage, permanent damage that's happened in the liver. So either there's nodules in the liver, or there's scarring, or a special type of scarring called cirrhosis. So something that's not reversible, and there's been some structure damage. So those are the more severe cases. But then there's also this whole spectrum of what we call hepatobiliary, and that's a fancy word for liver bile duct involvement with CF, which can be a wide range of things, and it's diagnosed if you have an abnormal physical exam, if your doctor feels that the liver or spleen are abnormal in size on the physical exam. If your blood tests, your liver blood tests that we screen once a year, if there's an abnormality that's there, persistently, not just once, but over time, even just one lab value. And then third, if you have an ultrasound, any ultrasound abnormality. So it could be fatty liver, it could be big liver, not the permanent damage, but just something's abnormal in the ultrasound. So those are kind of the two concepts. And then looking in the registry, this is kind of grouping it all together of this generic term of CF liver disease. We can see in the graph on the bottom, that is a population sort of age distribution. And you can see gray, it represents everyone in the registry, how many people are at certain ages. So you can see it's a pretty young age distribution. And the blue little hill within it is those who have been labeled in the registry as having CF liver disease. And what I want to point out about this is that unlike some of the complications, we talked about complications are more likely to occur as we age with CF. Liver disease is a little bit different because especially the more serious type like cirrhosis, it can actually start to develop in childhood and adolescence. So you see that little blue mountain is happening more, the slope is going up starting at age 10, 20, which is a little different than some of the other complications. So it needs to be really considered and thought about sooner. And then on the right side of that, as you can see this sort of low level, this is throughout all of the ages, it sort of looks like there's only, somewhere between 10 and 20% of people have CF liver disease. But again, as I mentioned, it can be very subtle. That liver involvement people may not have symptoms, and it may not be labeled as such. So really an area that we're paying attention to. I'm going to skip that chart and go to this. So what are we doing at the foundation about liver disease? There's this network that's called the CFLD net, and that's a liver disease network, centers across the country where there's specialists called hepatologists. There's GI doctors that are gastroenterologists, and then you get additional training if you're interested in the liver, and that's called hepatologists. So it's a network, and it's a collaboration between the CF Foundation and NIH, where we support these centers that are kind of powerhouses for doing research studies and thinking about liver disease. And some of the studies that have been done that have been really important over the last several years, there's something called PUSH study. It's a kind of a cute name, but that's basically looking at the role of ultrasound. Just doing, you guys have probably had an ultrasound of some sort. It's where you put the jelly on and you look with the probe. There's no radiation, but just looking at the liver with an ultrasound, starting ages 3 to 12 in kids, and seeing if that could predict who may develop cirrhosis. There's also a component of that study where certain people got an MRI on top, just looking at what are the different ways to image the liver that could be predictive of developing liver disease. The next one is an elastic study, another cute term, and this is evaluates a special kind of ultrasound called a fibroscan, and that's what you see in the picture there, where it actually sends sort of like sound waves out and kind of picks up on how stiff the liver is. How easy do those sound waves move through the liver, and so it's like a liver stiffness monitor. And that seems to be more important in people that we know have some liver disease, and you want to see, is it getting worse each year? So there's a couple. So we have MRI, we have ultrasound, and we have this elastography, or the FibroScan, measuring liver stiffness. And as a result of all of these studies looking at, the best ways to diagnose and monitor liver disease, there's updated guidelines. We talked a lot about clinical guidelines. This is what all the doctors around the country and care teams around the country look at in terms of how they should be, what's the standard of care for treating people with CF. And there was a group of experts, including people with CF and their family, that have gathered over the last 2 years to work on updating liver disease guidelines in CF. And they're in preparation and probably going to be published later this year. And this will be an update from 1999, which was the last guidelines that were put out there. And there is a couple little differences, new things that came as a result of these studies, including screening for liver disease every 2 years for everyone with CF with an ultrasound. So stay tuned for those, and we'll be sharing them out with our care centers to make sure everybody knows what the latest approach is. I'm going to let Erin tell us about the next segment, which would be CF-related diabetes. Another video.
Thank you. Although this is not looking like it's a video. I was going to let one of our experts in the field of CF-related diabetes, Dr. Andrea Kelly, did this great video for the CF Foundation. She deals with pediatrics and adolescents and does a brilliant job of explaining what CF-related diabetes is and what she's excited about in this kind of new era of CF. But it looks like our video might not play. So I will do my best to explain CF-related diabetes briefly. As you can see, we've gone through a bit of a pattern with each of our sections. What is it? Sharing some data, because we love data, and then what is the CF Foundation doing? So with CF-related diabetes, it's a little bit different than your typical type 1 or your type 2 diabetes. It's not really either. It's more closely related to type 1 diabetes in the fact that oral medications don't work. So if you have CF-related diabetes, most people need to take insulin to manage it. So I think that's a really, really important point. They cannot just take a pill to manage their diabetes. So we'll just go right into the data trends. CFRD is associated with a lot of issues with weight loss, lung function decline, and an increased mortality. But early diagnosis and treatment really could minimize this impact. And so some of the data trends that we show here, again, this is age distribution, and we're seeing most people with CFRD diagnosed in their adolescence and adulthood, mainly adulthood. And of the individuals in the registry who have been screened, the prevalence of CFRD is higher in that adulthood and adolescence population. And this next slide shows our patients over 18. And again, this is not from a registry report. We were fortunate to have our colleagues pull this for us just for today. But it's showing us the distribution of, in the orange, that is CF-related diabetes. And you'll see over the past couple years, it's been pretty consistent that 30% of the adult population has CFRD. That's a lot. And then when you look at the blue, that's something we called impaired glucose tolerance. So those individuals may not quite yet be to the point where they need insulin, but they're on their way. So if we combine those two, we're pushing 45 to almost 50% of our adult population having to manage CF-related diabetes. And the vast majority of individuals diagnosed with CF in the registry are treated with insulin, which is our recommendation. And the treatment burden of CF alone, I'm preaching to the choir here, is very, very high. When you add diabetes to this, it becomes extremely overwhelming. So insulin needs can vary, oftentimes needing more insulin when you're sick, having an exacerbation versus when you're doing well. And there are certain situations where people might need insulin for a year or two and then end up not needing insulin. But for the most part, when you're diagnosed with CFRD, you have diabetes and you're on insulin for the rest of your life. So this leads me to some research highlights. What are we doing about this? The PROMISE study, I think we heard about that the first day of our time together, is a really, really unique real-world observational study to help us understand the effects of Trikafta in clinical use in the US. And what's really cool about this study is that there are a lot of sub-studies under this, looking at all of the different organ systems, one of which is related to CF-related diabetes. The Parent Promise study is collecting some very baseline data on lung function, BMI, symptom quality of life, as well as change in sweat chloride. But as I mentioned, some of these sub-studies, one of them focusing on CFRD, is looking at how Trikafta impacts people with CF-related diabetes. We don't have a great understanding of that right now, so we're using this data to try to help us improve our knowledge of that. This is collecting data, the CFRD arm of this is collecting data on insulin requirements, episodes of hypoglycemia, so when your blood sugar is dropping extremely low, and it's looking at glucose tolerance tests, so most of you have probably heard of, that's how we determine if you have CFRD is by the ever unpopular oral glucose tolerance test, where you have to drink that sugary drink and wait 2 hours, and we look at your blood, and that's what helps us decide your status with CFRD. So it's looking at better ways of trying to determine CFRD and not solely having to rely on the oral glucose tolerance test. The next study is the Spectrum study, and this really aims to provide insight into how more aggressive CF-related diabetes, so aging, how weight is impacted, race and ethnicity, how do these things contribute to the development of CFRD? How do they contribute to the complications? There are a lot of complications of diabetes, eye issues, kidney, nerve, heart. So this study is really aiming to provide insights on how we can detect these. And then the next one, which is really, really exciting, it's called ILET, and this is the bionic pancreas. And this graphic is a little interesting. It's kind of two studies put into one. The background, that's the New England Journal. There was a publication published, I think it was the end of last year, looking at a bionic pancreas in people with type 1 diabetes. The bionic pancreas is basically a fully automated artificial pancreas device. So it's not a surgery. We don't go in and implant a device. It's really, for those of you who know what a continuous glucose monitor or an insulin pump, it's essentially like an insulin pump that talks to the glucose monitor. And it's a closed loop system that the person wears, and it bases the data off of your weight, and it's able to adjust your insulin levels based off of that and machine learning. So using machine learning to continuously adapt the person's insulin requirements. And they did this for 2 weeks, and it was very successful. So we had an investigator at Mass General who decided they were going to do this looking at a small portion of their patients. We wanted to know how this translated to those with CF. So they were able to conduct a small single-center study with 20 people with CF, and they had great results. I actually just talked to her before I came here to get the latest update. She presented at the North American Conference. And what they did is they did usual care, which is whether you're on insulin injections or an insulin pen, or you are considered usual care, versus those that were on the bionic pancreas for 2 weeks. And they looked at the time in range, which means your glucose should be between 70 and 180 are kind of the parameters. And our goal is to get you inside of that range for the majority of the day. So they looked at how long are people in that range. And with usual care, it was in the, I think, 50s. And then with the bionic pancreas, it was almost 75%. So there was a 12% increase in those with the bionic pancreas. So they're putting together a multi-center trial to look at this in more of our CF population, which is extremely exciting. And then lastly, we'll talk about CFRD guidance. So what are we doing for people with CF and their families? One of the things we do have available is managing CF-related diabetes. It's for individuals with CF and their families. It's a guide to help the clinical management. We actually just revised this. This is an image of the 6th edition, but we just revised it, and hopefully by the North American Conference this year, we'll have the 7th edition published. And the 7th edition adds some really important aspects of CF-related diabetes management that we didn't have a couple of years ago, such as continuous glucose monitoring and insulin pumps. Next, there's updated CFRD guidance in pediatric diabetes. Now, this was not directly driven by the CF Foundation, but it has a lot of experts on this that helped write these guidelines that we have partnered with throughout the years. So it's the International Society for Pediatric and Adolescent Diabetes, and they have updated their consensus guidelines, and these came out in September of 2022. and they are published in Pediatric Diabetes. So again, really novel approaches to how we can better manage and make this a little bit easier for people using continuous glucose monitors, insulin pumps, instead of having to do daily injections multiple times a day. Next, we do at the Foundation have our own clinical care guidelines for CF-related diabetes, which are available to our care teams to help guide them. And then lastly, I'll just mention this workshop that was co-sponsored by the NIH and the CF Foundation. We convened a group of experts in June of 2021 to help us identify key research, questions, and knowledge gaps related to CF-related diabetes. How do we know the disease mechanisms? Help us come up with better treatment options. And I'm happy to report that there is a newly accepted paper being co-published in the American Diabetes Association Diabetes Journal, as well as Diabetes Care. The downside to it is it's been accepted, but it hasn't been published, so I can't share all of the details, which is why it says available soon. Stay tuned. Hopefully in the next couple of weeks, we'll have some updates on our website and some messaging that goes out to let you all know that this is available for you to read. So stay tuned. And then we're going to switch it over, liven things up a little bit with fertility and some anatomy.
Yes, so if you zoned out a little bit, look up. A little bit shocking. So let's talk about fertility. We heard about pregnancy a little bit earlier, but I want to start with male fertility. And on the left here, you can see the male anatomy. And you see, I don't have a laser pointer, but do you see that white dotted line? And that is the fundamental problem with male fertility in CF, which is that the vas deferens doesn't form, so or is destroyed while it's being formed. So effectively, most men, over 99% of men that are born, will have an absence of the vas deferens on both sides. And the vas deferens, you guys have, some people have heard of people actually subjecting themselves to a vasectomy. That's the same concept. The vas deferens is the white dotted line that connects the testes, where the sperm is made, to the seminal vesicles, where the semen will be then prepared for ejaculation, and then it ensures that the sperm gets to where it needs to be for ejaculation. So in the absence of that does not mean that fathering a child is not possible. It just means it's a little more difficult. It's a plumbing issue. So there are procedures to remove sperm directly from the testes under sedation. Don't worry, under sedation, so testicular sperm extraction is the fancy term, and then that is used either for insemination directly into the woman, or in vitro fertilization, which is where it's in a dish first. The egg is retrieved from the woman, put with the sperm from the man, and it gets to an embryonic stage and then reimplanted. So take-home message here is that the problem is the absence of the vas deferens, that it can be overcome by fertility treatment. So that's for men. If we take a look at the diagram for women on the right side of the slide here, so you can see at the bottom that is the vagina that leads up into a more narrow passage there, which is the cervix and the uterus, and then the fallopian tubes are the little things that look like big ears coming around and then you can see the ovaries where the egg is released. So what I want you to notice here is that there is no anatomical abnormality in women. I mean, all of that, there's nothing that didn't form correctly. But what the issue is that recurrent theme here, sticky and thick body secretions, and there is mucus in the cervix. It's called cervical mucus, and so in women with CF, that is thicker and stickier, and it basically acts as it can slow down the passage of sperm as they swim up and try to fertilize the egg. So it's almost like a built-in, not spermicide, but it makes it less hospitable for pregnancy to occur in an implant. Not impossible. We've been seeing, as we saw on the graph, and I'll show you again, women with CF have been having pregnancies successfully in the past. But what's different now is with modulators, and in particular Trikafta, the impact on the CF protein being able to work to normalize the salt-water balance and thin the secretions all over the body have resulted in thinner, more normal constitution of cervical mucus, such that fertility for women, they're doing studies to determine exactly how it compares to normal, but I've been telling my adult women to consider themselves on Trikafta, that consider their fertility essentially normal. So, and to consider taking action if they don't want to get pregnant in some situations. So, those are the sort of male and female issues. This was a graph that we saw. So women, as you can see over the years, pregnancy has been successful, just a little bit harder because of the thick, sticky cervical mucus. But now, remember, Trikafta was approved in October of 2019. So we see that big jump up in 2020, 2021, up in the 600s. And then last year, you guys saw, I think, the soft number that's not published yet is 631, so still up in the 600s of women reporting that they were pregnant last year. And so the Mayflower study that we heard about, that's this is sort of a list of what are we looking at the CF Foundation in terms of taking action in the area of reproductive health. The Mayflower study is a study that women with CF can enroll in, and they're studied throughout their pregnancy, and then the infant is studied for the first 2 years of life. And that's for people on modulators and not on modulators, because we want to know all of the different impacts of pregnancy on both the woman and the infant in the early stages. And to date, over 100 women have enrolled in the Mayflower study from around the country. And we may hear some early results this summer at the European CF conference, so that'll be really exciting. But what the diagram here points out is that building a family, having a family, doesn't just have to come through pregnancy, as we all know. So there's different ways that people can be parents, through adoption, through surrogacy, step-parenthood, foster care. So all of these family-building options have to be considered and are actually being studied in a joint study that's being sponsored by the NIH and also by the CF Foundation called the HOPE CF study. And that is really looking at health outcomes of being a parent, both on mental health and physical health, and both for men and women. So that's pretty exciting to just see how does, we all know that if everybody's, or those of us who are parents here, changes life forever. But if you have a chronic, for the better most of the time, but if you have a chronic disease, how does that impact health and mental health? And we need to know that. And then lastly, just wanted to share that no pun intended, the SHARES is the working group that's really driving where we are putting our attention, where we are designing studies. This is a group of investigators and clinicians and patient family members around the country that are on a working group to really direct all of the efforts that the foundation is making in reproductive health. So I think we'll hear a lot more about this in the years to come. Okay, so we heard about, let's review, we heard about colorectal cancer. We heard about advanced lung disease and transplant. We heard about liver disease. We heard about diabetes. And we heard, lastly, about reproductive issues related to CF. So that's a lot of things for the CF care team to keep up with and for people with CF and their families to keep up with. So this is a sort of new concept that we have looked at where we're thinking about the expanding CF care team, that it's not just, we have the patient in the middle, and we always fundamentally keep patients at the center of our care approach. And we have the required team members, the kind of traditional, and that dark blue inner circle, traditional team, physician, nurse, social worker, dietitian, respiratory therapist. Recommended team members in the next band, which would include pharmacists, mental health coordinator, PT. But really what I want to draw your attention to is this outer band of other specialists. And this is other specialists that we need to get excited about CF, we need to educate about CF, and we need to bring into the CF fold to partner with us to help take care of all of these CF-related issues. Some are going to be CF-related issues with aging, and some are going to be normal aging issues, but with a little twist because people have CF. And we can see as we go around the circle, that includes things like gastroenterologists. We talked about why that's so important. Endocrinologists, for bones and for diabetes. We have, I need my glasses, ENT, we have transplant physicians, and not just, as Erin pointed out, not just lung transplant, liver and kidney, other types of transplant physicians. We have OBGYNs, like we talked about, for women having babies. We have the primary care physician, a new role that we really need to integrate. And then urologist, and I'm going to give a shout out to Larry over here, who we've had conversations about kidney stones and other things that happen that we didn't get to cover, but urologists, and I've had kidney stones myself, urologists are going to be really important for both they deal with male fertility and they deal with kidney stones, which are actually higher rates of kidney stones in people with CF. And then palliative care physicians, which are people who help manage symptoms over time, like pain and other symptoms. Psychiatrists, we know, are critically important for some people. Rheumatologists for arthritis and bone health, and then lastly, genetic counselors for family planning. So we have this make the circle bigger, and we have to entice these specialists to really partner with us to make this kind of specialized care available across the country. And so what we're doing at the CF Foundation, this is just some of the workforce development programs. This is ways that we reach out to different individuals and say, come work with us in CF. Let's give you a grant. Let's fund your research, or let's fund some of your time, your practice time, so you can think about how to take care of people with CF and how to work with us. And so what we know is that this needs to happen really early in training. So even to medical students, as people have ideas in medical training that what they want to do pretty early. So we do have a summer research program for medical students that they go to CF Care Center and they have a project, and that starts getting them introduced to CF. We have for residents, internal medicine residents and pediatric residents, before they know if they want to be a pulmonologist or gastroenterologist, we give them the opportunity to apply and be funded to come to the North American CF Conference and interact with some of our specialists and feel the excitement and see the care teams and the researchers from across the country. So those are, and then we have the early career awards that you see listed. Those are to support research and fellowship training. And then on the right-hand side, we know that there's this need for more and more adult CF doctors, so we have a program to support adult doctors that are new to CF for 3 years, so they can focus some time and energy on CF, and specialists like endocrinologists and GI doctors. And then lastly, other care team members, and to include things like APPs, advanced practice providers, so nurse practitioners and physician assistants. We're just starting the second round of supporting a program to invite APPs or PAs or NPs to come into CF, partner with physicians and learn how to be what I call a CFologist, and entice them to come and help be part of our care team. And then there's other programs, additionally, pharmacist, PT, mental health. And then something that I think is really, really effective is discipline mentoring programs. So anyone that's new to CF, we have many programs where they could be, for example, take a pharmacist. They can be paired up with a more experienced CF pharmacist, even across the country, get that connection point, maybe even go visit each other, have mentoring. And I think that really, we've shown that it really makes a difference in job satisfaction and staying in the field. So with that, I don't know if this final video works. A repeat from earlier. What we see is that there were more pediatrics for the longest time, and then several years ago we hit the equal point, which is that dot, and now more and more adults in the blue, a growing segment, and then the projection out to 2040, where much more adults than kids. And that's why we need to prepare the workforce. We need to have the specialists ready, working with us, and these are the ways that we're attempting to do it. And I'd love to hear questions or concerns from the audience. Thank you. No. Oh. It's so good. It started to play again, but let's. Larry's going to help with the mic too. Yes. And we're going to, for the people online, we're going to repeat the question. So let's see. I'll stand here and Erin can stand there, and we'll see who's best.
So while you're waiting to entice these people to come on board, how are you working with the care centers, with the care team, to build relationships with some of these specialists so that when the CF patients need one of these specialists, they have someone they can refer to? Because at my son's clinic, that's a huge issue.
Right. Absolutely. So I think, at larger CF programs, they may have the benefit of they have enough specialists where they have someone who is their CF endocrinologist embedded in their clinic, and that's awesome. But for a lot of the other care centers, they're working with, and they may not be in an academic center, and they're looking to endocrinologists or GI doctors or liver doctors in their community. And so it is, and I can say as a practicing physician, I feel much better when I have someone that I know personally, that I communicate with regularly and I have confidence in, that I can say, I want you to see this person, not just go through the phone book and find someone. So I think relationship building is absolutely critical. So there's some programs, for example, like the Digest program, which is the program where we fund gastroenterologists. They're usually at academic centers where they partner with the care team closely. But now we have programs where they can be invited to give grand rounds, either virtually or in person. They can visit smaller programs that don't have a GI doctor, and then they can invite their local GI doctors and have an expert either come physically or come virtually and just generate excitement and knowledge. But ultimately, that it's an incredibly important question, and I think it comes down to, like most things in life, relationship building. And the more cases that you have, and I find that with my own practice, that sending people to the same person over and over again so they can accumulate experience in CF, talking with them, building relationships and communicating is critically important, because not all care centers are going to have the luxury of having someone come into their clinic and be right there. So it's a huge concern, and something that we're talking about a lot. I don't have an easy answer for that, but it's on the radar. Thank you for bringing that up.
What time are we here until?
12.
So I think we're over time.
Are we?
I don't want to hold you all here because I know there's lunch. So I just want to say thank you very much. Find Whitney or I if you have other questions that we weren't unfortunately able to get to. But thanks for being here. Have a great lunch, and we'll see you later.
Yes, thank you.